Welcome to this week's podcast of Kicking It with Kidneys with your host, Cindy Barclay. Hey, Cindy, take it away.
Hello, friends, and welcome to another episode of Kicking It with Kidneys, a forum to discuss important topics for the historically suppressed voices in the dialysis community. Now, during our last episode, our guests discussed timely topics related to COVID-19 vaccine hesitancy within the dialysis community and minorities. We also talked about the historical and cultural experiences that affect health outcomes for minority patients and the challenges that create quality of lifestyle difficulties. The topic of today's discussion is kidney disease. What is kidney disease? Now, in order for us to understand why minorities have a higher rate of kidney disease, we need to define what it is, the causes of kidney disease and renal failure, and the social and economic disparities that affect healthcare practices in our community. To explore today's topic, our longtime friends, Maria Jimenez, who is a registered nurse and the administrator of quality dialysis, Rita Williams, who is a licensed renal social worker, Sarita Scarborough, who's an MBA in business administration, and of course, B.J. Simone, master's in sociology, health services researcher, and trainer. Now, so B.J., what is the word on the street?
Well, hi, Cindy. We took our mics out and asked a few people on the street what they knew about kidney disease and renal failure.
All right, let's hear.
Word on the street with Simone.
Hey, Simone, we out on the streets today. We asking people what they know about dialysis and what they know about renal failure. And this is what they said.
I don't know anything about renal disease. I do not know anyone on dialysis.
I know some things about renal failure. It doesn't, well, put it like this. From what I've seen, it's really up to the individual and how they're taking care of their body, different things. I've had a cousin who had a heart transplant, and it ended up being renal failure and not his heart, because he had to be put on dialysis because of the medications that began to affect his heart. I know another lady who's currently on dialysis right now, but I don't think she's going into the renal failure side of it as much. It's more about fluid buildup. Now, if that's a part of renal failure, then I guess it is. But fluid is building up on her legs, and she's swelling, so she's going in to dialysis to get the fluid off, from what I understand.
Okay. Can't say I'm very knowledgeable of that subject. REANL, I've heard the word used, but I can't say I'm very knowledgeable of the subject. Being part of the Black community, I realize it's an ailment that tends to touch a lot of fellow brothers and sisters. So I have had the experience of knowing a few people that underwent dialysis in my lifetime.
To my knowledge, renal failure is when the kidneys are not functioning properly. A person hardly makes any urine, if any at all, and they have to go on dialysis because the body's not cleaning what goes in it and passing it through the body properly. Previously, my sister, who passed away last July, was on peritoneal dialysis, where she performed dialysis at home every night.
Okay, so there you have it from people on the street. And what we see is that the range of understanding about kidney disease and renal failure spans from knowing nothing at all to secondhand knowledge based on experiences of family and friends.
That is correct. That is correct.
Okay, and so our question becomes, why is this the case, especially when we know that 37 million people in the U.S. are affected by this condition? And as reflected by the responses from people on the street, I think that part of the answer might be the image or the perception of the condition.
Okay, so we're going to get into that, but first we're going to have Maria kind of give us a definition of renal disease, the primary causes, the symptoms, and diagnosis.
Sure. Thank you so much for having me on today, Cindy. So chronic kidney disease, or CKD, it's a condition characterized by a gradual loss of your kidney function over time, which also decreases the ability to keep you healthy. Many people don't realize the role the kidneys play in keeping you healthy. They are very powerful chemical factories that remove waste and excess fluid from the body. And as the disease process gets worse, waste builds up to high levels in the blood, and that makes you feel sick. The two main causes for CKD are diabetes and high blood pressure, which counts for 2/3 of the cases of diagnosed
that's pretty high.
Kidney disease. Most people may not have any severe symptoms, though, so it can go untreated or undiagnosed until it's advanced. And by that point, you're feeling tired, having less energy, trouble with concentration, poor appetite, trouble sleeping, swelling around your ankles and your eyes, dry skin, itching. The actual urge to urinate more is a possibility as well. But all of these are, preventable before you get to this point. Just by visiting your doctor, and what your doctor will look for in your labs is the GFR to help diagnose the stage that you are.
How many stages are there, Maria?
There are 5.
Okay.
There are 5
and
stages.
we'll get into that in other segments. Okay. All right.
Sure. But basically, your doctor will calculate your GFR based off of your creatinine.
What does
test.
GFR mean?
That is the glomerular filtration rate.
And what does that mean?
It's a combination of numbers that they put together based off of your age, race, gender, and blood creatinine test as well.
Okay, so they do a lot of testing before they diagnose you.
That is correct.
Okay, so as we know, obesity and chronic kidney disease soar in many cultures around the world, but African Americans have been the hardest hit. Since there is no future without a past, we are going to address certain truths as it relates to disease among slaves, mental illness. When we were transported to the United States, basically, it was a cultural shock to us. Would you say that, BJ, that it was a cultural shock? That when we left Africa and we came to the United States of America, that we're looking at a cultural shock because we didn't know the language. We didn't understand the people, So there was mental illness. In other words, we just are overwhelmed with a whole new environment. Do you have anything to add to that?
When we start looking at the historical consequences,
Yes.
Particularly slavery,
Yes.
and how it has affected the African American community.
Yes.
In all aspects. Health. There are so many areas of health consequences that are really tied into what you said: our diet, our levels of environmental stress,
Right.
And so that's a huge topic to really unpack.
Right.
Without just simply sufficing to say that, yes, our historical experience as a people has had long-range effect on our health that we're experiencing today.
So some of the diseases that we have: mental illness. We also have unsanitary conditions, and we have improper nutrition. Now, what we look at is that it was a plant-based diet basically in Africa. I'm assuming there were a few sheep and goats that they ate. However, we weren't really introduced to a certain type of food until we got to the United States. All right. And we're going to deal with that later. Rita,
Yes.
give me your input give me an overview of the disease in the Latino community.
With mental health in the Hispanic community, it shows similar vulnerabilities to mental illness in the general population, but they face disparities in both access and quality of treatment. The inequality puts the Hispanic community at a higher rate for more severe and persistent forms of mental health conditions because without the treatment, the mental health conditions often worsen. So back to some of the barriers that you were talking about that the African community deals with as well. We also deal with the language barrier. A lot of times families that do seek out assistance or for mental health, or they try to find a counselor that speaks their language, but it's hard sometimes to find. I mean, you can go to a non-Spanish speaking counselor, but they sometimes use translations, and a lot of things are lost in transit. The translation of
and within
mental
the
health.
Hispanic community, aren't there different dialects?
Yes, they are.
Okay.
I mean, we all fall under the same umbrella, but we carry different, like you say, dialects, a lot of things we do different. Just because we're considered Hispanic, we're not all the same.
Yes.
So also, of course, the therapist out there and the legal status.
Yes.
And the stigma.
Yes.
Who wants to go to a mental health professional? Because we don't want the neighbors to say, hey, Rita went to see the therapist and, she's kind of cuckoo. That stigma of that, it's real hard, especially in the Hispanic community.
Okay, so let's get into some numbers. With chronic kidney disease, African Americans are at 33%. We're 3 times higher to have end-stage renal disease than the white counterparts. I was sad to hear Native Americans are at 30%.
Yeah.
Okay. BJ, you've done a lot of research and work with the Native Americans. Hispanics are at 28%.
Right.
Asians are at 26%. And of course, whites are at 23%. Now, when you look at patients on dialysis, we have a problem. Houston, we have a problem.
That's right.
Whites are 13%. Okay. Latinos are 14%. Asians are 13%. Okay. But African Americans are at 16%.
Wow.
So it seems like the progression of the disease is growing. However, as far as the literacy within these minorities, it's a problem there.
Right.
And I guess, how do we address this and how do we deal with this in the communities? BJ, you're in sociology, okay? So my question to you is, can you elaborate on or give me your analogy regarding, your thought process on this disease, since a lot of people think that this is a disease of choice.
Yes, and I think partially, Cindy, that because kidney disease is closely linked to patients managing other primary conditions, like you said, there's a common belief that kidney disease is caused by lifestyle choices. And there's no consideration that there are other influences such as education and income, political climate, environmental conditions that people may have little or no control over.
Right.
And when you look at it from this viewpoint, there's a tendency to blame the patient with kidney disease for his or her own condition.
Well, I think we're at a point now in society or in life to where we have to have accountability. The blame game has existed from the beginning of time.
Right.
So since we know that the blame game will continue, what do we do, or what can we do, Maria? What can we do to help ourselves out of this rut that we're in? Because it seems like the generational curses.
Conversation.
Conversation.
Just talking about it.
Okay.
letting everyone know that it is real and that it does affect a population of patients, people, I should say. Conversation, just start talking about it.
Right.
No one's talking about it.
Right. I think, Maria, that's very true. I know that in the Latino community, we have to continue to stress to get tested for diabetes, to get tested for high blood pressure, to get tested for that heart disease, that all is part of this kidney disease. I mean, and it's like you say, having that conversation.
Or just accepting that, my great-grandmother had diabetes.
Right.
My grandmother, my mama, so it's just bound for me to happen. Just bound to happen to me.
So you're trying to say intervene?
Is what it is. Well, in the sense of this is just how it's always been. So this is how it's going to be.
So we should not expect any help from anywhere else, right? Other than ourselves. So we have to work from within.
Right.
Is that what you're saying?
That is exactly
okay.
what I'm saying.
BJ, what are your thoughts on that?
One of the things that in preparation for our talk today, one of the things that I did, I conducted an exercise, and it's an interesting exercise. I would invite anyone to do it, but I paid close attention to the commercials and the public service announcements that were played over the course of a weekend.
Oh, wow.
And
you've been busy. You've been busy.
What I found, no, it's very interesting. What I found is that not once during that whole time did I hear any information about kidney disease.
Oh, no.
But or particularly things that were related directly to kidney disease. I heard information on diabetes, cancer treatments, psoriasis, COPD, insomnia, eczema, buzz driving. I even saw a commercial for canine treatment of arthritis. But I didn't see kidney disease.
Oh, wow.
The only thing I heard about kidney disease was as a potential side effect of a very popular drug or medication that's used for another well-known condition.
Okay.
So, I think that's just we simply don't hear. And I think Maria said, talk about it. The kidney disease is just not in the public eye. We simply don't hear enough about it.
But why are we so quiet about kidney disease? Why is it quiet? As I spoke of in our previous shows, there's a lot of money. And I updated my knowledge last night with the United States Renal Data Systems. They're saying up to $48 billion a year. We're at 7 to 8% of the Medicare budget.
Wow.
It seems like a small population. I think you mentioned, BJ, that there was 37 million.
37 million. That's from the CDC.
Okay.
2021 numbers.
Okay. So, Sarita, we have a problem. You know about money. Okay. Let's address this.
Well, I use the United States Renal Data System as well, but I guess for the record, we always need to say that their hard numbers are 2 years behind.
Correct.
And so my data is from 2017. And all of this information is available on the USRDS website, and I'll make sure to share it with you so you can post it on your website so those who want to look in more detailed information. But the bottom line, in 2017, the total Medicare portion of the budget as it relates to dialysis was $35,901,987,082. Now,
it's a lot of money.
Lots of money.
For a small population of people. That we never hear anything about.
Right.
I mean, we have these wonderful organizations like the National Kidney Foundation and the United States. I mean, they're doing everything that they can, but I have a fear that they're not reaching the population of people that they need to.
Right.
Continue, Sarita. I'm so sorry.
Now, if you do a per patient average based off those numbers, that was working out to $79,931 per patient on an annual basis.
And that was in 17.
That was 17.
It's now 2021, and it's up to $90K per person per year.
Yeah. Wow. So I guess one of the things you have to look at is, and I'm stepping a little out of my lane, but I think I understand it. But when you deal with who is eligible for Medicare, that's when they meet a certain coordination of benefits,
Correct.
correct?
30 months. 30
months. And these people are also at that time claimed as federally protected or disabled.
Yes.
Which now we have to look at this amount of money being spent versus their value to society.
Oh my.
Wow.
Can a disabled person work? And so I'm not sure if they can or if they can't, but now we're talking about this small percentage of the population and what are they contributing to society. Now I also understand we have our private health care insurance, but they're working.
Right, but hold on a minute. Rita, isn't there something that's in the Medicare guideline that relieves employers once you're diagnosed with end-stage renal disease, okay? They don't have to. We'll look at that in the next show.
Yeah.
But I think it is, and we're going to bring that back up.
Okay.
But I think it takes the burden off of employers, which further devastates and causes more economic disparity.
And were you talking about where it switches over to Medicare being primary and then the private insurance being secondary? Yeah. After those so many months, that's when that happens. And and the insurances are ready to do that switch. They're reminding the patients that if they don't have Medicare, to go ahead and apply at that time.
Yeah, but I think there's some real realities to the cost associated with employers. I'll give you an analogy. You've been working for a company for 40 years. You've retired. Now all of a sudden you get chronic kidney disease. Does that make you a less valuable person because you're no longer participating in?
It doesn't make you a less valuable person, but when you're doing the math and you're looking at, because businesses are based off of productivity levels.
Right.
Yes.
And if you're out 3 days a week for so many hours for treatment, or what have you, then quite naturally you can assume that one's productivity level would be less than 100% healthy, fully capable working individual. So I don't want the employer to discriminate based on a medical disability. However,
but they do.
From a business perspective, I have to look at what is financially most beneficial for me. And I appreciate your 40 years of loyalty. Maybe I just need to give you a package and let you enter early retirement and send you home and actually take a young 21-year-old college graduate, pay them less money because they're new into the marketplace and raise my productivity back up to 100%.
Do they actually give out packages anymore, BJ? I mean, do they? Packages?
Retirement
packages. I thought that
I think that's based on your job.
They do.
Work.
You know, it seems to be a thing of the past. It seems that the value of a person is becoming less and less. Now, I don't know whether that was induced by lack of employee commitment or whether it's just that in the U.S. we are so capitalistic.
I think it's back to money. Like we always talk about, it's always back to money.
Follow the money trail.
Follow the money trail.
Well, I know that in some of the larger corporations, there is a practice that when a person becomes too financially a burden to that company, they will tend to downsize. They go through periodic downsizing. And this is a way that they can get some of those top-heavy benefit packages.
Right.
They can reduce that. You're 25, maybe you've got 25 years, and they will go through a downsizing period. And that's a good way of weeding out those people that are costly to the company.
I think what's more detrimental, Maria, is that a lot of the patients that I've seen become complacent and they feel like they're always going to have the support of the federal government to take care of them, not understanding that the providers of dialysis and CKDs, the physicians and everybody else, the cost is going up. So basically the problem is, how do we get those individuals to be more proactive with their care and stop ignoring the fact that when you go into the hospital, it's a burden on the system. Medications are a burden on the system, okay? And we have to start, these generational curses are being passed on. So do you think that, what do you propose that we can do, and on what level?
From an administrative oversight, with our QAPI looking at numbers, the facilities are the ones that are hit over the head with decreasing money that they get from Medicare on an annual basis based off of clinical outcomes. These patients do not have any recourse.
I like that. So are these clinical outcomes realistic? Let me give you an example. Are we comparing somebody that's bedbound, okay, tube feeding and everything else? How can you comparatively compare them to somebody that has hypertension or diabetes and on dialysis and able to walk into? So basically, when you say outcomes, are you saying that the providers are going to get less money to provide the same services to the patient that's bedbound?
That is correct.
Wow.
They put everybody in the same bucket, same basket.
Yeah.
Okay.
They share
These
the
are the
same money.
standards.
Yeah.
They don't care the type of patient population that you have. Bottom line is the bottom line. Here are the numbers. If you don't meet them, then your facility is dinged financially, and you're still expected to run a organization to have good staff that cares about the patient. Number one, continue to educate your patient and run a facility. Supplies, medications. They're adding medications to the bundle for dialysis. More and more every year. There's something new. But again,
so they're requesting more,
not.
Right? So the government is requesting more as far as oversight, but they're giving us less to do.
And I guess it's their intent to try to get numbers up that way.
But how can you get numbers up? I mean, that's an interesting thought. How do you get somebody's numbers up when you're not there to actually put a spoon in their mouth or to stop them from doing certain things? You got to remember, we can teach and tell them what to do. But it would seem to me, Rita, that they would have to make a choice.
Right. The patient has to choose to implement the changes that we talk about or educate about. And,
it's their will.
It's their will.
Because there's some that come on, they have no education. They're brand new to dialysis. Those are the ones that are great, to get started because they actually see the light at the end of the tunnel. A lot of patients feel like, okay, I've hit rock bottom. I'm on dialysis anyway.
Right.
So why do I need to care about, what I'm eating or what I'm drinking? I'm going to get on this machine every other day to clean me out. And again, that's just a part of being comfortable with your disease process.
And I think along the way, as social workers and dietitians and nurses, we educate our patients. I mean, sometimes we educate you and we're blue in the face and with the patient, and you're like, this is like the third time I've educated the patient, but you continue to educate and you hope and pray that at one point, Mr. So-and-so will, the light will come on.
So, Sarita, where are we headed? Money's getting tight. People are not understanding. I think, let me give you a little analogy. I went to the mall, I think it was Easter weekend, and I saw a lot of people out there. I think they're getting the stimulus checks now. And I thought to myself, this would be great if they would spend this money into educational type self-help tools in our communities. Do you understand what I'm saying? I mean, Sarita.
Well, the purpose of the stimulus, the purpose of the stimulus, though, is to put the money back to get the economy kicked off. I think one of the things, though, that you guys have been talking about is the kidney foundations versus Alzheimer's and those types of things.
Yes.
And I think one of the missing factors is that people are not connecting the dots. That as a derivative of diabetes, as a derivative of high blood pressure and hypertension, the long effect is renal failure. And so I think that's how it kind of gets missed. So, it may be thoughtful to say, okay, Alzheimer's or whatever comorbid organization, what is your component to talk about the consequences when a person doesn't follow the diabetic diet? And are they teaching that the end result is going to be renal failure, and as a consequence, you're on dialysis?
Well, I think we do. BJ, how do we change how do we get people to kind of be more compliant and to change the way that we do what we've always done, because this is what we were taught?
But I think Sarita hit a point there. When you look at the public appeal for conditions such as diabetes or Alzheimer's or cancer. There's also a component that there's a spotlight for the juvenile or the elderly cases that's made in the media. And I think that also reinforces this idea that there are some illnesses that aren't the fault of the patient. And I don't think that is the same in the case of kidney disease. I think, as she was saying, kidney disease is seen as a consequence of not managing these other diseases. And so, again, you still see that, well, it's their fault. The blame is on them, as opposed to this embracing of these other diseases that just sort of came on people with it wasn't their fault, and therefore there's a need to help them.
But I think also, isn't that a pattern that minorities, where we have a lot of disparities, but if you follow the money trail, minorities are really not, as far as spending the money. Okay, well, we spend a lot of money. We spend a lot of money, but it's $2 trillion a year.
We're some of the biggest consumers.
Consumers that they are.
Market.
Okay, so do you think we need retraining as to how to accumulate wealth and to help ourselves as far as lifestyle, and what are we going to do to help the next generations?
Okay, I absolutely see that. I mean, we can go back to listening to today our people on the street.
Yes.
It's clear they don't have a full understanding of what kidney disease is, what the risk factors are, why it's important to know anything about them. Kidney patients are, for the most part, they don't stand out. I mean, you don't go to the grocery store and say, oh, you're a kidney patient.
Yeah.
You don't.
Yeah.
The treatments, you heard our people this morning, the treatments, they know a little bit about it.
Yes.
For the most part, the treatments for kidney disease or renal failure is done in silence. And so there's this quasi-invisibility that surrounds the development of an attitude of out of sight, out of mind. I don't have to worry about it until I have to worry about it.
Right.
And we've got to counter that. We've got to make, especially when you think about how many potential new kidney patients.
Yes.
We've got to make it important. And I think when you take all of this in consideration, it might explain why we don't see in the general public this the same level of awareness and advocacy we see for other diseases.
But the expenditures and the financial burdens that's associated with it, somebody's capitalizing.
And there is some there.
Okay.
Yeah.
Okay.
There's some there that I think we can explore fully. Probably not in the time frame we have today.
Correct.
Definitely.
Correct. Okay. So in this segment, we have defined kidney disease, the primary causes, symptoms, and diagnosis. We have also discussed its economic burden to families and the healthcare industry within the minority communities disproportionately. Now let's get some final thoughts from our panelists. Maria.
Continue to strive to just talk, open your mouth, and educate your neighbor, your family, and it has to start from your home unit and then spread outwards. I see dialysis patients every day, so I continue to educate them, which what I don't see every day is people in pre-renal. But anytime anybody asks me what I do for a living, we talk about dialysis and kidney disease, and you don't want to see me. I'm not the nurse that you want to see. So just open the mouth, talk, and get some education and just talk about it.
Okay. Sarita.
Well, I think it always goes back to economics, and one of the things that I'm going to be looking forward to exploring and doing some research here real soon on is connecting the food supply. Because when we talk about the cost of dialysis, we also have to talk about the income of the Medicare patient and what their cost of living expenses are.
Yeah.
Right. And then we start seeing a different trend on that end, which I'd be interested in hearing BJ's insight to that when I can bring that data to the table and have that conversation.
Wow. Okay. BJ.
Okay, I think that we have to continue to provide sources of information such as this program, and then also push for more prominent profile in public awareness of kidney disease in general. You know, it really does suffer from an image problem.
And Rita.
For my final thoughts, Hispanics are the largest minority group in the U.S. We contribute to the economy, the cultural diversity, and the health care of the nation. Assessing our health status and our health needs is the key to inform health policy formulation and the program implementation. We want to stand up and be counted, ladies.
All righty. Well, thank you guys so much. I'd like to close this segment with a quote from Dr. Martin Luther King. He says, "There comes a time when silence is betrayal, and we by our silence become conspirators within the evil that is destroying us all." We hope that you have enjoyed this segment of Kicking It with Kidneys. Please join us next week, or with our next segment rather, when we'll continue with part 2 of our discussion on chronic kidney disease.
Well, that's it for today. Thank you for listening to Kicking It with Kidneys with your host, Cindy Barclay. See you next week. The views expressed on this podcast are educational and opinion-based. These are not medical doctors.